So I'll be doing case discussion on NEC. I'm Dr. Mitali Rao. I'm a fellow at Wadia Hospital. Case 1, this baby is born very preterm at 30 weeks of gestation, is a female neonate with extremely low birth weight of 860 grams, born to a 24-year-old primary mother by normal vaginal delivery and had cried immediately after birth. This baby was transferred to Wadia Hospital on day 3 of life for preterm care. Antenatal history. 2 antenatal scans were done, which were normal. There was bleeding PV, which was followed by premature rupture of membranes. Steroids were covered. Course in outside hospital. This baby was intubated and mechanically ventilated soon after birth, and there was early surfactant administration. There was gradual decrease in ventilatory settings. There was no PDA on 2D echo screening. This baby was kept NBM and was on total parenteral nutrition, and the sepsis screen was negative. Course in Wadia Hospital. From day of life 3 to day of life 4, this baby dynamically filled with settings, and hence was rapidly weaned from nasal CPAP to triple HFNC to room air by day of life. Feeds were started and were gradually increased and this was EBM. Multiple episodes of hypoglycemia were noticed, requiring high BIR of 12. Since the hypoglycemic episodes were not corrected, once feeds reached 100 ml per kg per day, cornstarch was added, keeping the feeds isomolar to maintain high carbohydrate delivery. USG skull was done, which was suggestive of multiple cerebral abscesses, and neurosurgery opinion was taken, who decided on conservative management with antibiotics for this baby. On day 25 to 26, this baby developed feed intolerance, had multiple episodes of vomiting, which later on became bilious. However, the abdomen was soft and the bowel sounds were present. Initially, the X-ray and the USG abdomen done were normal. From day 27 of life, there was rapid deterioration of the baby. The abdomen had a progressive worsening with distension. The abdomen was tense and shiny. X-ray was suggestive of fixed dilated bowel loops. USG was suggestive of peritonitis. This baby's ventilatory requirement went up. The increased abdominal pressure was leading to respiratory compromise, initially requiring non-invasive ventilation, and then was mechanically ventilated, requiring high pressures. Baby went into shock, requiring multiple inotropes, including adrenaline, noradrenaline, and hydrocortisone. The sepsis screen was done, which also showed worsening, and antibiotics had to be stepped up. PCV, platelet, and FFP transfusion was given to the baby. Initially, a glove drain was put on day of life 28. However, since the glove drain did not show any much advantage and the abdomen continued to worsen, this baby required surgery. This baby was operated on day of life 31. Post-OT, the stoma was not functional from day of life 32 to 42, and the abdominal distension was still present. However, the respiratory wise, we were able to taper the ventilatory settings. Inotropes were tapered and stopped, and there was response to antibiotics, which was suggestive with subsequent sepsis screenings. However, on day 43 of life, there was worsening with increased pressure requirement. There were frequent desaturations. So a repeat 2D echo was done, which was suggestive of pulmonary artery hypertension. This baby had to be then shifted to high frequency ventilation, requiring INO. Gradually, the baby went into refractory shock and hypoxemia. The sepsis screen had subsequently worsened also. Despite best resuscitative efforts, the baby continued to worsen. The second case, this baby is a 30-weeker born at 1.5 kg weight, male neonate to a 27-year-old G2A1 mother by normal vaginal delivery. This baby was transferred to Wadia Hospital at 9 hours of life for respiratory distress and preterm care. Antenatal history. Baby's mother is a known case of clinical depression on tricyclic antidepressant and multiple benzodiazepines for the past 4 years. The ANC period was uneventful. There was leaking PV for 3 days prior to delivery, and there was preterm premature rupture of membranes. Steroids were not covered. During the first 6 days of hospital stay with us, we were able to gradually wean the baby from CPAP to room air. Screening USG skull was suggestive of grade 1 GMH and the sepsis screen was negative. As the baby was stable, feeds were started and full feeds were reached by day 4 of life. Because the mother was not available and was not, formula feeds were initiated for this baby. On day 7 of life, baby had an episode of seizure and needed to be loaded with Levera. On day 11 of life, there was worsening in the form of feed intolerance. There were greenish aspirates and bowel sounds were sluggish. On investigation, the NEC triad was present. The NEC triad of thrombocytopenia, metabolic acidosis, and hyponatremia. The X-rays and USG abdomen done were still normal. Gradually, the sepsis screen had worsened. Baby went into shock and needed to be intubated. On day 12 of life, the X-ray was repeated again, which shows the classical soap bubble appearance. The USG was suggestive of early NEC changes. Baby had already been kept NBM, and shock-wise, the baby had shown worse response to inotropes adrenaline, which were gradually tapered and then stopped. Baby had refractory seizures requiring phenobarb and Midas infusion, Midas infusion was tapered and stopped after 48 hours. Blood culture was suggestive of Enterococcus fecalis and antibiotics were changed according to the culture and sensitivity. From 7th day onwards, so from day 12 to day 16, baby was continued to kept NBM. Baby was NBM for a total of 7 days. Day 17 of life, a repeat USG abdomen and an X-ray abdomen was done, which was normal. The abdomen was soft. Baby had already been extubated. So now we were able to restart feeds from day 18. Feeds were gradually increased at 20 ml per kg per day. And by 25 days of life, we were able to reach 120 ml per kg per day feeds. Baby is tolerating feeds well. Third case is a 3-day-old baby born IUGR with a birth weight of 1.35 kg. This baby is female, born to a 27-year-old primary mother at 37 weeks of gestation. This baby was referred to Wadia Hospital on day of life 3 in view of respiratory distress since birth and low birth weight care. Antenatal history. This baby is born to a primary mother. 4 ANC scans were done, with the first ANC scan done at 3 months of amenorrhea was suggestive of fetal growth restriction. The fetus followed the same centiles during the antenatal period. There was history of white discharge for 3 days prior to delivery. Course in outside hospital. This IUGR neonate with a ponderal index suggestive of asymmetric IUGR was transferred to NICU soon after birth. This baby was kept on O2 by prongs for respiratory distress. Given feeds, mainly formula feeds and fluids. IV antibiotics, injection ceftriaxone, amikacin were given, which were then upgraded to injection meropenem. And sepsis screen, however, was negative. This baby was transferred to Wadia Hospital on day of life 3 in view of persistent respiratory distress and very low birth weight. During the first 2 days of hospital stay, oxygen was gradually tapered and stopped. There was asymptomatic polycythemia. On admission for KF5 was kept, were established. They were mainly formula feeds after consent from parents in view of poor count, and the sepsis screen was negative. This baby was only on first-line antibiotics. However, with attention. So next slide. Fees were held, sepsis screen was repeated, which was positive, antibiotics were upgraded. Investigations were also suggestive of the NEC triad of thrombocytopenia, hyponatremia, and metabolic acidosis. USG abdomen was done with suggestive of mild ascites with few echoes, mildly edematous bowel loops, and however the peristalsis was preserved. Next. This baby was kept NBM for NEC stage 2. However, the baby was hemodynamically stable. Sepsis screen, consecutive sepsis screen showed improvement. On day of life 14, after keeping the baby NBM for 7 days, feeds were restarted. Feeds were increased at 20 ml per kg per day, and baby reached full feeds on day of life 22. Antibiotics were stopped after 7 days since the cultures were also negative. Thank you.